Good afternoon. I'll be moderating the next panel. I'm Akhil Saklecha from Artiman Ventures. So what we'll be discussing next is really about adoption of technology in healthcare. And we have a fantastic panel that are not only CEOs of large organizations, but are also physicians in their own right and have had tremendous experience in their careers in managing healthcare issues, medical issues, and administrative and business issues as well. So we should have really a great discussion on how to think about technology adoption in healthcare. So in order to introduce the panelists, I thought it would be helpful to talk a little bit about the medical background and then a little bit about the companies they represent. So first, Paul Beaupre on the left. Paul is an anesthesiologist, did fellowship training in cardiovascular anesthesia. He's been a board-certified anesthesiologist for 22 years, and is in that capacity, as you can imagine, really understands the inner workings of the hospital. While he's been at Good Sam, he's had steadily increasing administrative roles, going from Chief of Staff, VP Medical Affairs, Chief Medical Officer, and Chief Operations Officer. And then about five years ago became CEO of Good Samaritan Hospital here in San Jose. And just a few comments about Good Samaritan Hospital as well. So Good Sam is a 500-bed nationally recognized hospital here in Silicon Valley. It is owned by HCA, which is the largest private hospital corporation in the US. Good Sam is also the first hospital to be certified by the Joint Commission from the American Stroke Center, Primary Stroke Center. They are also one of the only 10 hospitals to be given the Outstanding Achievement Award from the American College of Surgeons, Commission on Cancer, for 4 consecutive years. They have 800 doctors on staff, which, by the way, is more than the state of Wyoming. Additionally, they have 2,500 employees and over $1 billion in revenue. Now, Wes Curry, on Paul's right, is an emergency physician. He has been practicing and still is practicing for 35 years? Is that 35 years? Now, he's progressed from a staff emergency physicians into the role of CEO of CEP America for about 20 years now. And he's been influential at health policy at the national and state level. He's also led the expansion of CEP America to become a national organization to covering 150 hospitals, multiple specialties in 12 states. They're actually now one of the largest staffing organizations for physicians in the US. They cover 1,700 physicians, 1,000 physician assistants and nurse practitioners, 1,000 medical scribes, which is an up-and-coming industry. And they have overall 3,000 employees when they look across not only the physician staffing piece of CEP, but also getting into billing, coding, physician management, as well as malpractice. Now, all of those physicians staff nearly 5.2 million patients a year in the US. And once again, over $1 billion in revenue. So these are large organizations and obviously very experienced individuals. So with that, I'm going to step over and we'll be talking a little bit about I think the technology adoption. So when I think about new technologies that have come into healthcare, especially over the last, I would say, 10 to 15 years, we've seen things such as the Da Vinci robot. We've seen novel point-of-care tests. We've also seen new drugs. We've seen a lot around EMRs and healthcare IT. All of those things are novel inventions and definitely have an impact on healthcare. And it'd be great now to hear from Wes. Maybe if you can talk to me a little bit about what you see as a physician, and then on the CEP side of adoption of new technology, how things happen.
Sure, thank you. I kind of see it in 4 broad areas. First of all, as physicians, we staff the emergency departments, but we also do anesthesia, hospitalist, and post-acute care, skilled nursing facilities, urgent care centers. So with all the physicians and also the PAs and nurse practitioners, kind of four big areas. One is knowledge and education, and mostly in diagnostic areas, therapeutic areas, procedures, devices, and just education in general. The other one is the electronic health records and also information transfer, and that means information transfer between patients and physicians, physicians and other physicians, physicians in the hospitals, healthcare facilities, physicians and the payers, and on and on and on. So there's a whole ecosystem that we work within our hospital clients where we really rely on information transfer. I think the other thing has to do with performance and measuring the performance of the physicians, various metrics like how long does it take for the physician to see a patient when they first arrive? How long does it take for the patient to get through the whole process and be discharged from the hospital or admitted to the hospital? So there's lots of metrics that we have to follow, quality issues and also patient satisfaction. And the final thing has to do with the whole infrastructure behind trying to treat 5.2 or 5.3 million patient visits per year. And that has to do with the billing, the management support, credentialing, and so many other aspects, and even the back office stuff that has to do with how do we actually track, credential, and reimburse or pay all of those providers and get them to the right places at the right time, because we're in 12 states and we basically run 24 hours a day, 365 days a year, nonstop. So it's a big enterprise, and I think there's some real opportunities to look at how these systems work, because I think this is how healthcare is going. You're seeing consolidation, not only of hospitals, but you're seeing consolidation of physician groups into ever larger and larger entities who will be prepared to help manage patients in the future in this new sort of health era.
Paul.
Well, I think, first of all, that it's really difficult for entrepreneurs in your position to think about what are the best portals to get new technology into hospitals. I'd like to dispel the rumor that the only place you can do that is through the university setting. Good Sam being part of HCA runs 168 hospitals in the country. They have large research arms and actually funding arms within those hospital systems. I think one of the things that entrepreneurs do many times is they believe that the best way to do this is through a relationship with a physician champion. And that's not necessarily a bad idea, having a physician champion. Many times I get ideas coming across my desk that comes from a very active physician on staff who's seen new technology at a meeting or has a relationship with a startup. One of the pitfalls I think you have to be careful of is the OIG has put a lot of burdens now into having physician-owned companies dealing directly with hospitals. So if you're contemplating having a physician as a member of your startup, I would advise you to keep that person in an advisory level or on an advisory board, because if they actually take an ownership position, that could become an impediment to getting your technology into the hospital, simply because of Stark laws and anti-kickback laws and things like that.
So you brought up an interesting comment. So how does an entrepreneur actually connect with both of you? I mean, for Wes, do they come and see you as a patient for an ankle sprain and then say, by the way, I've got an idea? I mean, how do they do that? How should they?
Well, there's a couple of ways. First, we have a fairly large management company as well. We have an innovation committee, and often people contact me directly. And then what I would do is forward those requests to our chief medical officer or operations officer, And then essentially, we would go through the process of helping others really understand if there's a place within the enterprise that technology might be useful, so to speak. So I think that there are other things. We go to trade shows, for instance, the professional associations and trade associations, and there are many technology companies there who are displaying their products, which have to do with how we take care of patients, various devices, technology that has to do with patient information, records, data analysis, and on and on and on. So that's another way to contact physicians and really others in healthcare organizations, is to attend their trade associations.
I'd like to amplify on that a little bit. In my world, first of all, you know, as many of you that run companies or are starting in startup companies, we are very beholden to our budget. So it is difficult to come in and pitch a new idea once the budgets are set. But what I'm very willing to do, since we're in such a fertile area for innovation here, is to have entrepreneurs come in. I try to maintain an open door policy. I actually schedule a couple of hours every week for opportunities for people within the community to come in and talk to me about new ideas. That's not necessarily for adoption at Good Samaritan Hospital, but if the idea is fertile, I will open doors within HCA for the entrepreneur then to move up the food chain, if you will, and get closer to where the decisions are made in those areas in Nashville and things like that. So there's communication is the key. You know, the answer is always no until you ask the question, and so you've got to certainly you know, make your introductions and things like that. And if you have something that's innovative or fills a need, then for certain we will help move that along and get it into the right hands.
So Paul, tell me about, you know, if you look at Good Sam, maybe some examples of new technologies that you've been involved in or the organization's been involved in.
We have a couple, I think, that are very interesting. A few years ago, we had a woman come in for delivery. She had a baby at 25 weeks gestation. So she and the baby were in the hospital for a prolonged period of time after the baby's birth. And during that time, her husband realized that there were so many things going on in the space of trying to run a home and managing the number of people that wanted to come in and visit with her, that he developed a software product that really through the cloud could manage all of that. She could schedule appointments with family and friends to come in at times when she wasn't exhausted, and she could actually request shopping online for grocery shopping so that the neighborhood didn't, on the first day, deliver 20 meals at the same time and things like that. And it was really a interesting way of looking at something that was very necessary. And so we got that in front of HCA right away, and now that's an application that we offer our patients when they're in our hospital. And then, you know, on the IT side, I think the hot area right now is HIPAA-compliant communication, being able for the physicians to talk back and forth with each other about patients in a safe, HIPAA-compliant way, and for patients to be able to access their records in a safe and HIPAA-compliant way. So we're seeing a lot of innovative and new technology coming into that space as well.
And do you know, by the way, how that app is going that you just mentioned?
It's very successful. It's now adopted in all 168 of our hospitals, and they are very pleased with the way the marketing is going at this point.
Okay. And Wes, I think donning your physician hat, you know, what are some examples that you've seen on the technology side, new technology?
Well, of course, there are many. As an emergency physician, I often tell my friends and family, you know, we might be the first one you see if you've been in a car accident. suffer a heart attack and other things like that. Plus, our patients arrive at unscheduled times, often with just all kinds of things you can imagine. And so it often appears to be a chaotic situation. But I think the real focus for, and I'm just talking about emergency medicine right now, is what are the new products or technologies that can help us see patients faster, help with the diagnosis, and also help us to communicate. And as Paul was just saying, a lot of this has to do with how do you do it in a HIPAA-compliant manner. So some of the things that I've seen come along, sometimes they're physicians, sometimes they're others. They're just these really neat things that allow you to do procedures in a more competent manner, so to speak. There are people, for instance, there's products like Hippocrates, if you will, which is essentially a concise software program that provides information for physicians on not only diagnostic, therapeutic, and procedural things. Another one is Up to Date, for instance. So there's a lot of things that really, I think what I'm saying, that can just pull in data from many different sources and put it in front of the physician there. And likewise, the use of scribes, which he mentioned. You know, the physicians are constantly seeing patients, and so if they're in front of a computer, or if they're not actually seeing a patient, then it's really not productive time. It doesn't generate revenue for the providers. And so I think that if you think about problems or solutions that you can come up with, it's really how do you keep the physicians in front of the patients, and so all that other stuff that surrounds them is there. So I'll just say one thing. My son is a scribe, and one of the things that person does is literally stay right with the physician. They're like their second brain. They can find things, they can talk to people, and then they can help summarize the medical record and put it in the proper format so that the physicians can be paid. But also, you got to remember the government is watching. You know, if you don't document it, you didn't do it. And so the thing is that what physicians now are under a great deal of pressure to be able to provide all this information for people who are actively essentially trying to measure for quality, and they're also trying to figure out things that they, to be honest with you, that they cannot pay you for because you didn't document it or it wasn't done in the proper way.
So Wes, you mentioned something interesting right now. So the way I see it, the scribes really bring, they impact the physician workflow, and that becomes an efficiency area, and obviously it helps the top line and bottom line. So obviously, I think working on the workflow issue and helping that process makes it almost a must-have type of solution. If you think about other, companies' ideas, people that are talking to you about new technology, what are these hot button areas where you think, wow, if I could get that, it's a must-have? Are there some examples of some hot topics or hot ideas, or even the opposite of that, which are turnoffs, which are things you hear about and you're like, wow, not going to work at all. It's not helpful. I mean, just
Right.
things that are instinctive.
I'll start with the second one first. I think you always have to ask the question of, let's talk about the turnoffs. If this is going to introduce another significant cost into the process of seeing patients, if it's actually going to delay the time that you can do throughput, and if it's going to complicate the process, then those are typically very difficult issues, and usually, if you have all three, can be a non-starter. And so you kind of have to know what are the questions. On the other hand, if there's something that's going to allow you to facilitate seeing patients faster, to provide documentation better, or to get information to the physician in a timely way to help that physician or provider make a decision, I think those are things that are really positive. What's interesting is that in our experience, scribes, and most of these are college students who want to be pre-med, and they usually stay for 2 years, and so there's a pretty big turnover. But since I've practiced for a long time, before electronic records and all that, we used to take one piece of paper and we could write down a bunch of notes and we were done. Now there's just tremendous amount of documentation, and frankly, I think the physicians, you might see the same experience. We actually spend more time with the paperwork and documentation than we do with the patients, and that's not a good trend. But I think scribes, for instance, continue to add to what we're doing because essentially they can take over a lot of what the physician is searching for, whether it's x-rays, labs, talking to people, connecting with people, and documenting things. And eventually I see the new type of practice that as the physician is examining the patient, someone's recording this, and it could be multiple ways of doing it. Google Glass has been used in some of our facilities, audio transcripts of that. And one of the first technologies actually was the Dragon voice recognition software that a lot of physicians still use today.
Can I just amplify on that for a second? I think as an industry, we're lagging way behind many of the industries you're used to because we were late to the game with lean technology. And talking about a turnoff, when we got lean finally, it was a bunch of industry-driven people talking to us about how lean worked in the automotive industry. It really wasn't applicable to the healthcare industry at all. So if you're designing something and thinking about something, if you can design the technology and make it healthcare applicable, that's really important. So what we did at Good Samaritan Hospital was Virginia Mason Clinic, outside of our system, but really had adopted lean technology to the healthcare industry. And we sent up a group of our managers and directors and learned about lean as it applied to healthcare, and that made all the difference in the world. So I think many times some of the bigger companies that try to introduce things into healthcare try to introduce a product that's worked well in a production line or something else, but really haven't thought about the ramifications of how it should work in medicine. And that would be a big starter for a lot of you if you were thinking along that way.
I'd like to add to that too. Let's just remember point of care, POC. I think that's really a hot area for us because, first of all, I'll just talk about some technologies. Ultrasound. Previously, that was the purview of the radiologist. You had to schedule a person to be there. It could take a couple of hours. But now the newer physicians out of residency are learning to be proficient in doing ultrasound, which has sort of revolutionized the practice because, I mean, you essentially, when the patient initially arrives, you could scan them and see that they're suffering from, say, an impacted gallstone. You can find foreign bodies. It guides you in terms of doing procedures so you have fewer complications. The other things are the testing. Over the years, point of care testing now gives us laboratory studies, the various blood tests, if you will, that literally are available within minutes compared to 1 or 2 or 3 hour turnaround times. And I think that there's just so many others that have really come to fruition, even technology which actually interviews the patient prior to seeing the provider. So that what happens is that software can actually, sort of using probabilities, if you will say, these are the major areas that you should focus on. And in many ways, it also may be the technology that allows us to screen whether people are sick and requires the services of a provider, or if their symptoms are, say, less acute, which would allow them to be referred to a lower level of care so that they would actually not have to come to the emergency department at all. And so what we're seeing now is a lot of telemedicine technologies where people can use their cell phone and iPad and other things like that to actually see a provider who is remote. at literally all times of the day. So that's going to be a tremendous thing. And the other thing I would add is look up Donald Berwick. He's been a sort of a real key, I think was the president of the Institutes of Medicine and was with the CMS. And if you go to the CMS website, I actually think it will help a lot of entrepreneurs to understand that the triple aim of improving the patient experience, also improving quality, but also doing it at a lower cost. And I think that if you can focus on those type of things, you will be coming up with solutions, because this system is really now forcing hospitals and providers to do things better at a lower cost, and it's essentially impacting healthcare in big ways.
So we're near the end of our panel, but I have one last remaining question. You know, when you look at in each of your areas opportunities or problem areas that are definitely worth solving, you know, for each of you, maybe you could give a couple of examples of problems that are just begging to be solved, and technology could be a harbinger of success there. Could you give us some introspection into that?
In the hospital, if any of you have been patients or have loved ones in the hospital, you, I know, are overwhelmed by the number of wires and gadgets that are attached to that patient. And then there's that phenomena of alarm fatigue, where the nurses hear so many bells and whistles going off the time that there's a tendency to ignore those, which can be catastrophic for a patient. So anything that can be done to really look at wireless technology, anything that can be done to really instruct and help the healthcare personnel with alarm fatigue, those would be wonderful areas to be thinking about and getting into.
Mm-hmm. One of the things I would suggest is I feel like the space we're in is what we call patients with acute conditions. And once again, the CMS has defined this as transitions of care. They want to see patients safely move from one healthcare area to the next in a safe and efficient manner at a lower cost. So one of the really big problems is when a patient enters the system, how do we track that patient through the system? They might enter as an urgent care center, the ED, they might come from a nursing home, but if there was some way that when a patient just arrives, maybe they've got a wearable, they've got some way that they can be identified quickly, we can understand that this patient was in the hospital less than 30 days ago, or maybe was at another hospital, so that we can pull that information in without having to repeat it and lose a lot of time. And then at the same time notify the key people like patient navigators, social workers, or any of the team who essentially can come together, evaluate this patient, and really try to understand whether that patient can avoid a hospital admission or if they really have to be there. So sometimes it isn't that you need new technology, it's what you have to do is connect the technologies that are already available.
So I'm just going to ask maybe a couple questions from the audience. Everyone talks about hospitals being the biggest cost element and look at dehospitalizing healthcare. How do you see hospitals as a business coping with this trend?
Well, first of all, hospitals is part of the cost. It's not the biggest cost in healthcare. Actually, R&D is one of the biggest areas of cost in healthcare. But one of the things hospitals are working on right now and absolutely have to work on is transparency of their charge masters. It makes absolutely no sense that when you walk in as a patient, you're charged $10 for an aspirin. This is a byproduct of back in the day where simply the way hospitals continued to increase profits was just by raising charges, and that day is over. So you will see some major changes in the way that billing for health costs in this country get changed. I'm a huge proponent of rewarding quality and rewarding for patient experience and making healthcare accountable for outcomes. I think that's the right direction. We should be doing that. I think that you will see that healthcare costs over time will go down. However, remember that as healthcare costs go down, the population, on the other hand, are going up. So I'm not sure it will make a huge difference in GDP as we go forward.
So our time's up. I'd like to thank our panelists for a very interesting discussion and just sharing your thoughts. So thanks, Paul. Thanks, Wes.